Today, we're going to be talking about the cervical spine and specifically unpacking some of the anatomy, kinesiology, and biomechanics that we see within this region. If you are interested in consulting some additional resources, you have those available to you. Those include Dutton's 4th edition, chapter 25, as well as Oatis's kinesiology text, the 3rd edition, chapter 26 and 28. Additionally, you can look at notes from A.J. Threlkeld, Oatis, Neumann, Dutton, and Cleland to further guide your investigation. So when we're looking at the cervical spine, there's really two portions that we want to consider. First, we want to look at the upper cervical spine, or what we might refer to as the craniovertebral region. This area adds about 25% of the height of the C-spine. Is primarily made up of C1 and C2, which is illustrated in this image. The lower C-spine is composed of the mid and lower cervical spine, level C3 to C7, with our typical cervical vertebra being from approximately C3 to C6. The posture is that of cervical lordosis, where the discs are slightly thicker anteriorly, and so there is this slight curvature, more concave to the posterior aspect of the spine, more convex to the anterior aspect of the spine. You'll also notice that the spinous process of the cervical vertebra is more bifid in the upper cervical spine. The body of the cervical vertebra are fairly small. They're about half as wide anterior to posterior as they are medial to lateral. There is a posterolateral lip, which is referred to as the uncinate process or the uncus, and it's a saddle shape that is given to the body and serves really two things. Number one, to stabilize the disc, but also to limit lateral flexion. And as such, this is a frequent site of spurring, and it's one of the reasons why we see side bending being a very sensitive range of motion measurement in order to give us information about possible morphologic changes within the cervical spine. The vertebral arch, also known as the neural arch, is a short horizontal spinous process. It's often bifid again in that upper cervical region. And then that gives way to the transverse process, where we find the transverse foramen. This is a area where the vertebral artery is going to pass. And the transverse process then provides protection for that structure. In the lower cervical spine, the articular surfaces, otherwise known as facet joints, are angled at about 45 degrees from horizontal. This is slightly different than what we see in the thoracic and lumbar spine, where in the thoracic spine, they're more 60 degrees, and the lumbar spine more 90 degrees. And this 45-degree angulation from horizontal allows for this element of rotation to occur. And it's one of the reasons why we see more here than really anywhere else in the spine. The major ligaments are the anterior longitudinal ligament and the posterior longitudinal ligament. And then C7 is really considered more of our atypical cervical vertebra. It's sometimes referred to as vertebral promens. The spinous process is the longest of the cervical spine. It's not typically bifid. Sometimes C6 is not as well, but C7 being more prominent. And it's part of that transitional area of cervical to thoracic. And so we refer to this area as the CT junction, or the cervicothoracic junction, where we are moving from an area of greater mobility, that being the cervical spine, to an area of more limited mobility. Now, just a moment ago, I mentioned the facet joints. Sometimes these are also referred to as zygoapophyseal joints, and or the articular pillar. They are synovial joints. There is an articular cartilage lining, and there's a capsule then that encloses that. Found within the capsule are small meniscoids made up of fibrous adipose tissue, and these can also be a secondary source of pain following trauma. In a neutral cervical spine position, the capsule is fairly lax. At the extremes of movement, it is tauter. And so when we're looking at a capsular pattern for the cervical spine, most texts agree that it is full extension with either side bend or lateral flexion and or rotation. And the reason why there's that slight discrepancy in the cervical spine is because you'll see momentarily, we introduce this idea of coupled motion, where side bending and rotation are coupled in kind of a 1-to-1 ratio. And so with that, let's talk a little bit about that. Movement in the lower cervical spine is flexion, extension, lateral flexion, or side bend and rotation. Extension and lateral flexion and rotation are the greatest in the cervical spine, as opposed to other areas of the body. Lateral flexion, again, is synonymous with side bend, but this is where we see this idea of coupled movement. That being that for every degree of rotation, there's also a degree of lateral flexion. And so lateral flexion is going to occur with ipsilateral rotation, same side rotation, once we get below that C01, C1, and 2 level. And as this happens, the vertebral body is going to rotate and the spinous process is going to go opposite. So if the vertebral body is going to the left, the spinous process is going to go to the right. Rotation also occurs then with slight ipsilateral lateral flexion. Again, these are coupled motion, whereas flexion and extension are what we consider pure movements, meaning they are planar type movements occurring in the sagittal plane. I mentioned a moment ago the capsular pattern. There is a slight question between lateral flexion versus rotation, but then also this element of extension. We've talked a little bit about the lower cervical spine. Let's pivot and talk about the craniovertebral or upper cervical spine. C1 is referred to as the atlas. C1 is going to hold the occiput and the cranium. There really is no body, but there are these broad lateral masses that serve as the articular surface for the occipital condyle. We do see a vertebral arch and then also transverse processes. The transverse processes are quite long, and they're actually palpable just anterior to the mastoid process and posterior to the angle of the mandible. And this is again where we see the passage for the vertebral artery. Articulating with C1 is C2. This is referred to as the axis. And the axis is interesting because it is an atypical vertebral body. It has a significant upward process known as the dens. The dens is the top of the body and also referred to as the odontoid process. But that dens is going to articulate then with C1, the atlas. And this is one of the reasons why we see such profound rotation occurring within the craniovertebral region of the cervical spine. There are facets here. Both the anterior and the posterior portion are convex, which allow for that articulation. Additionally, we see our transverse ligament here. We'll see that momentarily as we continue our investigation. The two primary ligaments that we are most concerned with within the craniovertebral region, since there is no disc in the upper cervical spine, would be the alar ligament and the transverse ligament. The transverse ligament also being part of the cruciform ligament. The alar ligament is a ligament that checks rotation of the skull on C2. A side bending of the head will cause the rotation of C2 in a contralateral fashion. And so when we check the integrity of the alar ligament, we typically palpate the spinous process of C2. We can side bend the head left to right, and the spinous process should move opposite our side bending. This is always assessed in the cervical exam following trauma. The transverse ligament serves to provide a check and provide support for the dens from C1 to C2. And it's again part of the cruciform ligament, and it helps to hold the dens against the anterior arch of C1. This ligament is typically assessed with a test known as the sharp purser. And again, this is always assessed in the cervical exam following trauma. However, two additional pathologies or conditions we want to be aware of would be rheumatoid arthritis and Down syndrome, where we see either erosion of ligaments or laxity, hypermobility of ligaments. The upper cervical spine, specifically the atlas and occipital joint, is specialized for flexion extension or nodding, a rocking motion. About 5 degrees of flexion of the total 60 to 75 comes from this joint, and about 10 degrees of extension of the total 50 to 75. And this really depends on where your resting position is. For example, if you have adopted more of a forward head posture, then you're likely compensating by adding this degree of extension at the upper cervical spine. The opposite would be a military head posture, which would have a good degree of upper cervical flexion. I mentioned a moment ago the cruciform ligament. There really are 3 portions, the transverse being the one that kind of gets the most attention. but there is also a superior and inferior portion. The transverse ligament stretches between the tubercles on the medial and lateral masses of the atlas and really connects the atlas with the dens of the atlas. Its function is to counteract anterior translation of the atlas relative to the axis. And so as such, it prevents the dens from impinging, if you will, upon the central canal and the spinal cord. Of clinical note, the function and integrity is crucial to prevent complications like a spinal cord injury or a vertebral basilar insufficiency, as well as to limit degenerative and inflammatory disorders. An interesting study by Dvorak and colleagues found that the tensile strength is approximately 330 newtons, or translated to more standard measurements, about 73 pounds. The alar ligament is connecting the superior part of the dens actually to the occipital condyles themselves. So it's C2 connecting to the condyles. And the function is really to resist a couple things. Number one, flexion. Number two, side bending and rotation. Again, those are coupled, but it's contralateral. And so side bending will help to produce that contralateral or ipsilateral rotation of C2. And also recognize that it's helping to restrict the AP translation. We mentioned a moment ago the intervertebral discs. We noted that the first disc appears between C2 and C3, and there is not one between 1 and 2. The nucleus pulposus, or more gelatinous material of the disc, is approximately 25%, and the height to vertebral body is about 2 to 5 in terms of ratio. This is the greatest ratio in the cervical spine. It's reinforced mainly anteriorly. We noted that ALL, or anterior longitudinal ligament. And it should be noted that once you're in your 4th and 5th decade, a process known as desiccation begins to set in, which leads to the nucleus pulposus beginning to dry out. And as such, individuals greater than 40 years of age have evidence of degenerative disc disease, and then by extension, degenerative joint disease and other morphologic changes. Cervical spine range of motion might be impacted by that degenerative disc disease. We'll pause on that for the moment and look at it through more of a typical pattern of movement. The first 10 to 15 degrees of motion is due to the movement at the OAA joint complex. So that would be C01 and 1-2. That movement is blocked when the posterior edges of the facets of C1 kind of lock into that condylar fossa. Then the AA joint, that being 1-2, begins to move, and it's kind of a cephalocaudal, so top-down progression from C2 to C7, though the exact extent and exact range of motion and degrees of motion that's occurring at each level are open to debate. Many individuals kind of adopt a holistic pattern of movement. Others adopt more of a sequential pattern of movement. The takeaway here is that spinal motion is inherently individualistic. As motion is occurring, the facets are gliding symmetrically. For example, if we're going into an extended posture, the inferior facet of the lower C-spine glides symmetrically downward over the superior facets of the vertebra just below. And that movement is checked by then the approximation of the joint surfaces, the tightening of the anterior longitudinal ligament, and even capsular restrictions at the zygapophyseal or facet joint, and then the compression of the disc itself. You can appreciate some of this movement as illustrated here from Oatis's text. You can appreciate that first C01 occiput on atlas, as well as 1-2 atlas on the axis motion. And then additionally, the intervertebral motion as we look at the facets gliding and sliding one on the next. Also, you can appreciate this idea of upper cervical versus lower cervical, craniovertebral versus lower cervical. And as we move into more of a protracted posture versus a retracted posture, more of that military posture, you can appreciate there's a difference here in terms of extension and flexion. Again, we've mentioned coupled motion. I want to put before you this idea that comes from Chad Cook, Eric Hedges, and colleagues in 2006, where they noted coupled spinal motion is the rotation or translation of a vertebral body about or along one axis that is consistently associated with the main rotation or translation about another axis. As such, we're really talking about rotation and lateral flexion or side bending, being consistently associated and coupled one unto the next. So let's look at rotation for just a second. I recognize this is a fairly word-heavy slide, but we'll do our best to try to break it down in a more digestible fashion. If we start from the top, there is little rotation that really is allowed to occur. It's more of a accessory motion at that A, O, or atlas occipital joint. The first 35 to 40, as much as 45 degrees of rotation is really occurring at C1 and 2, or the atlas and the axis. Near the end of that range, motion is going to slowly begin to restrict due to the tightening of the alar ligaments and the facet joint capsules themselves. And so then it's going to begin to move more into the inferior or lower cervical spine. And as we move into that area, the inferior facet on the side to which rotation is occurring is going to glide downward on the superior facet below it. That inferior facet on the opposite side, however, is going to glide upward, or more in a superior anterior direction on the superior facet below. And it's because of this that the result is that side bending occurs as a component motion, or as Hedges and Cook described it, as a consistently associated motion. It is this plane of the facets in the cervical spine then that result in side bending and rotation being coupled to the same side ipsilaterally. The return to neutral is the reverse of this process. Carol Oatis gives a nice graphic here to show this process occurring, beginning first at the atlantoaxial joint complex and then moving into the lower cervical spine. And you can begin to appreciate how each level is contributing to the global range of motion that we see. If we instead look at side bend from neutral instead of rotation, there's very little side bending that's allowed at both the 1-2 and the 0-1 joints. There's some slight lateral movement at C1 towards the side of the movement. You can think of a washer that's being shoved, but the cephalocaudal progression of side bending from C2 to 3-6 is essentially just as we saw with rotation. And so the vast majority of side bending is really going to come from C2 and below. Therefore, as we're assessing this, to keep the eyes pointed forward, oftentimes there is a compensatory counter rotation at the AA joint. So even though side bending and rotation are coupled, what's fascinating is that you're oftentimes able to keep your eyes facing straight forward, thus making it appear as if it's a planar type motion. For every degree of rotation that occurs, there's an equal and opposite rotation of the atlas on the axis. So this is a counterbalancing process that allows us to keep our gaze fixed in front of us, even if we're turning our head and neck. And again, you can begin to appreciate how this motion would occur. Again, very little glide and slide, more accessory motion for side bend occurring at that C01 level. Most of it's occurring in the subsequent C2 through 7 range. Another way to visualize this is side bending that's coupled with ipsilateral axial rotation. This would be probably C3 to C4. We still see the bifid nature of the spinous process, but you can see kind of superimposed here how that motion is occurring. There are several craniovertebral muscles that we want to mention. These include rectus capitis anterior and lateralis, the posterior suboccipital muscles, rectus capitis posterior major and minor, the obliquus capitis inferior and superior, and those are illustrated for you here with this image from Dutton's text. You can see how these are overlaid one on top of the next. They're very close in terms of proximity to vasculature and neurologic structures, and so individuals who are dealing with cervicogenic headaches or craniovertebral origin related headaches oftentimes will have these structures as a focus of an interventional plan of care. There are some superficial cervical muscles we want to make mention of as well, such as the upper trapezius, the sternocleidomastoid, the levator scapula, the rhomboid, specifically rhomboid major and minor, scalenes, the three aspect of scalenes being the anterior, middle, and posterior fibers and bands, and then ultimately the platysma, that real superficial muscle in the anterior neck. Additionally, there are deep cervical muscles. We see these as our paraspinals, oftentimes the cervical erector spinae, as well as the splenius capitis and cervicicis, splenius capitis and semispinalis capitis as well, being those more cranial muscles, sometimes also targets of suboccipital dysfunction. And then as we move to the anterior cervical spine, we see what are known as the deep neck flexors, longus colli and capitis, rectus capitis anterior and posterior. And these rightfully receive a fair amount of attention as we discuss the role of interventional care for the cervical spine. Deep cervical neck flexors do provide a good amount of postural support and even dynamic stability to the spinal segments. And so this is an area of interest and intrigue. You'll notice there's direct attachment to the anterior portion of the vertebral bodies, and so has a role here in providing that more dynamic stability. Finally, in our anatomy review, let's look at a few neurovascular structures. There are more nerve roots than vertebral levels. And so remember, we see the C8 nerve root, and yet there are only 7 vertebral levels. Part of that is because we are coming down from that OA and AA joint, and we see the greater occipital nerve there, oftentimes implicated from cervicogenic headaches, and then moving into the cervical spine, and then that transition from cervical to thoracic. The upper 3 nerves, 1, 2, and 3, are often implicated with neck and head pain. Once we get into the lower cervical spine, specifically 4 and 5, this is where we see more shoulder, upper limb, scapular pain and referral patterns. Keep in mind when we're talking about a single nerve root being irritated, that single nerve root is supplying an area of skin with sensory function. That's referred to as a dermatome. Oftentimes, when we are seeing referred pain associated with, say, for example, a facet joint, this is associated with a Bacodi sign, excuse me, not Bacodi. Bacodi would be associated with a radiculopathy that is also referred to as the monkey sign, but referred pain being a Cloward sign. A Cloward sign is a known referred area. It's oftentimes why we see 5, 6, and 6, 7 having referral patterns to the parascapular or upper trap jaw region. And those areas are going to overlap multiple dermatomes. So we want to be mindful of these terms, referred and radicular. They share similarities, and yet they are not the same. Additionally, we want to look at the blood flow. So this vertebral artery is applying 12 to 20% of blood flow into the basilar artery. And we also see carotid, suprascapular, brachial, and axillary here. But the vertebral artery can be an area of concern, specifically if we are applying more aggressive manual therapy or more end range manual therapy techniques, such as a high velocity, low amplitude thrust. And so we want to be mindful of that and be screening that when and where possible. Let's now shift our attention to biomechanics. My colleague John Fox would be very interested in this topic. And so as we look at the biomechanics of the cervical spine, approximately 50% of motion is occurring at the upper cervical spine, and then sharing that fairly symmetrically in the lower cervical spine. Again, we'll unpack this idea of coupling. Oatis notes, fundamental to developing an understanding of the cervical spine is an appreciation that each cervical vertebra contributes to the complexities of neck function neither equally or regularly. And this is an important concept that we be mindful of, because while there certainly are patterns, for example, coupled motion, it is difficult for us to say that it is always going to follow a specific pattern of top-down or more holistic motion. Yes, coupled motion is certainly something to be mindful of. However, beyond that, many of the motions are very individualized and are not something that are easily kind of ascertained. We've noted that the OA joint is made up of the occiput and the atlas. Recognize that this is a synovial joint. There's a capsule and fat pads here, specialized specifically for flexion and extension. We call this the upper cervical nod. So as the head nods forward, the condyles are going to roll forward, but then that's accompanied by a down and back glide or translation. The opposite would be true for extension. Very minimal amounts of rotation occur here. And so again, you can appreciate this roll, anterior glide and slide, posterior occurring at C01. For the AA joint, this being the joint between the atlas and the axis, we see that it not only accepts the load of the head and the atlas and transmits that load, but it also is specialized to allow for rotation. All right. And so the AA joint is really a pivot joint, and one of the areas where we see true spin in terms of an arthrokinematic motion. As such, the axis is an area we want to look at just a little bit more. When we think of axial rotation to the left, what's going to happen here is the left inferior facet of the atlas must slide inferior and posterior, and the right facet must slide anterior and superior. And this results in kind of this screwing down of the atlas on the axis during rotation. And this is important because not only does that provide stability, but secondarily, the alar ligament then also functions to restrain axial rotation. And so this is a fairly stable motion. Again, we can see that illustrated here, where the alar ligament becomes taut as we begin to move into end range rotation. Additionally, you can appreciate the orientation of the articular facets as that element of rotation occurs. We've already touched on the OAA joint as it relates to lateral flexion. Recognize that this does not result from pure lateral translation, but rather a roll and a glide and slide. So this would be more of an accessory motion. Next, we look at flexion and extension. Again, we've already introduced these concepts from an anatomy standpoint, now zooming in a bit more close to a biomechanical context. And so here, what we see is a sagittal plane motion where the inferior facet of the vertebra above is going to be gliding forward in a superior anterior direction for flexion, or backward, posterior, inferior for an extension fashion, and that occurs symmetrically on both sides. For cervical rotation and side bend, first let's start with rotation. During axial rotation to the right, we're going to see again this idea of contralateral inferior facet motion, and this is this idea then of coupled motion. For side bending, if we side bend to the right, the ipsilateral inferior facet impacts the superior facet below, and again, this is a coupled motion. How much motion is occurring at each level? This is a helpful way to think of it in terms of each individual joint. So the OA joint primarily is contributing to what we would again say is an upper craniovertebral nod. And so it's flexion extension. Very limited rotation and side bending occurs here. Whereas the AA 1-2, the major motion is rotation, and up to 45 degrees of motion will occur. You'll notice flexion extension, very small, side bending, very small. And so again, each one of these joints has a specialized function. The lower cervical spine primarily is going to be contributing to the remainder of rotation and side bending. That's approximately 40 to 45 degrees, but really contributing to flexion extension, 50 to 80 degrees total. Rotate and side bend again, same side, irregardless of whether we're in neutral, flexion, or extension. Now, some sources are going to vary a little bit on range of motion values. These are rough estimates where flexion is approximately 50 degrees, extension 60. Again, you'll notice there's a range here of 60 to 75, 50 to 75. And so again, that varies. Side bending, approximately 45 degrees to either side. So total arc of motion of approximately 90. And then rotation, up to 95 degrees, but really approximately 80 degrees. So total arc of motion there about 160 degrees. So as we summarize our understanding of the anatomy and biomechanics, recognize that the only significant arthrokinematic available to the zygoapophyseal joint is an inferior medial and posterior glide of that inferior articular process on the superior facet and a superior lateral anterior glide during flexion. Segmental side bending is therefore extension of the ipsilateral joint and flexion of the contralateral joint. Rotation, being coupled with ipsilateral side bending, involves either extension of the ipsilateral joint or flexion of the contralateral joint. So if we break this down, really the facets are merely flexing and extending, but they're doing so based upon is the motion ipsilateral or contralateral. All of this understanding of biomechanics is fantastic, and it's important that we recognize that we can help our patients and clients with this proper understanding. However, treat your patient and their impairments and or limitations and not just perceived biomechanical faults. You may identify something on your physical exam, but remember, it's only relevant if it's contributing to a limitation or as part of what we would call the comparable sign or their familiar sign. Treat the person, not just the pathology. So let's review. Vertical approximation, lateral flexion and lateral translation of C1 and 2 during rotation. You can see this here in neutral as well as with left rotation, and then left rotation and left side bending or right rotation. Combined motion testing, we can use a biomechanical model for this. For example, if we see a restriction of the cervical extension, side bending and rotation, and it is occurring to the same side, oftentimes this is something referred to as a closing restriction. This restriction is the most common pattern that we see, and it oftentimes can produce distal symptoms, that being either referred symptoms or radicular symptoms. And however, a limitation in flexion accompanied by the production of the distal symptoms can also occur. And so what do I mean by this? Well, imagine for a second, you are rotating and side bending to the left. Okay, as you do that, keep in mind the inferior facet is closing. It is approximating to the superior facet just below it. And so while the right facet gaps and opens, it being opposite, as you go into extension, right? If there is a restriction on one side, that one side is going to bind up, it's going to pause the motion. And so the opposite side continues to move. And so we refer to that as a closing restriction. And oftentimes side bending and rotation occurs at the facet that is having that issue with closing, but the other side continues to move. And so we see kind of this contralateral motion occurring. With the restriction of cervical flexion, side bend and rotation, we refer to that as an opening restriction. And oftentimes the compensatory motion then is a ipsilateral compensatory motion to the side where the restriction exists. This graphic is helpful as it illustrates an intervertebral or segmental contribution to first flexion extension, some more sagittal plane, and then lateral flexion rotation. We've talked about these concepts already, and you can appreciate just how much rotation is actually coming from 1 and 2, as well as how flexion extension is really specialized in that craniovertebral region, and then is contributed to somewhat evenly but unequally as well throughout the remainder of the lower cervical spine. So with this, we conclude our review of the anatomy, kinesiology, and biomechanics of the cervical spine. Hopefully this has given you a way in which to begin to conceptualize osteokinematic motion, the arthrokinematic motion, the contribution of active dynamic structures, supporting structures such as those more superficial and deeper layers to the cervical spine, as well as appreciating how these individual regions, the craniovertebral versus the mid and lower cervical spine, contribute to the totality of motion and function that we see.